Thank you everyone for watching this video. My name's Ian Soboleski. I'm a Senior Account Manager here at Cordant Health Solutions. And today we'll be looking at our Drug Testing 101 training. In this training, we'll be focusing on a handful of subject matters here. We'll start with testing methodology. So we'll take a look at screening tests, confirmation tests, what's the difference and some key things to take away. We'll then take a look at the comparison of the different drug testing matrices, the difference between oral, urine, and hair testing. And then we'll cover some common test interpretation questions. So diving into our drug testing methods here. Let's first start by clarifying some terminology. When we're talking about drug testing, there's actually two specific tests that need to be performed to obtain a positive test result. The first test is referred to the initial presumptive screen, and this is performed by immunoassay technology. The second test is the confirmation, and this is performed specifically in the lab, and this is done by LC-MS. The term screen should be reserved for the initial test and the term confirmation for that final laboratory testing. And how you should think of drug testing is the same way that standard practice in toxicology and legal defensibility does, which is this two-step process of testing consisting of the initial presumptive screen, followed by an additional portion of that same sample tested by a more specific and different technology. Screening tests are limited to being drug class specific. So for example, when we're looking for a drug, say opiates, the test cannot tell you which opiate is present, only that one or more may be. The screening test does not tell the difference between parent drugs and their metabolites. And most importantly, the screening test has potential for what's called cross-reactivity. Cross-reactivity in this form is when there's an unwanted substance that causes an unintended reaction. This is where a lot of people call this is what a lot of people call a false positive. So a perfect example of this situation would be in the case of a donor taking Sudafed. Sudafed is an over-the-counter medication that a donor can take for sinus decongestion. Sudafed contains pseudoephedrine, and pseudoephedrine can cause, in a screening test, the methamphetamine and or amphetamine initial screen to possibly come up positive. Now, there's a big difference between someone taking Sudafed and someone using methamphetamine, so we must perform further testing on this situation. Screening techniques are intentionally created to be fast and cost effective, and is kind of the industry standard beginning to drug testing. However, screening tests should really be looked at finding out what is negative rather than what is positive, specifically because of this cross-reactivity situation. And that's why confirmation tests are so important in understanding the whole picture here. We need more information on the initial presumptive screen. The second test in the lab, the confirmation test, as I mentioned, here at Cordant, we use LC-MS, and this is considered the platinum standard of the industry. LC stands for liquid chromatography and is well suited for biological samples such as urine, oral fluid, and hair. The chromatography is essentially taking the drug class of interest and separating out all the drugs within that class. The second half of the instrument is the mass spectrometer. This is the part of the instrument that counts, detects, and positively identifies the specific drug and the metabolites we're looking for. Now, this is done essentially by smashing the drug particles apart and then counting up the pieces by their molecular weight. No two drugs have this same pattern of these pieces, so this is what we call looking for the molecular fingerprint. Just like people, no two drugs have this same fingerprint. So when we run a confirmation, we've completely eliminated the possibility of cross-reactivity. So we know the specific drug that's present. We can tell how much of that drug is present, and we have 100% confidence in those tests being correct. Now, taking a closer look at immunoassay, or that screening test, here's the complicated science behind it. But what I want you to take away is the technology is built around an antigen antibody response. So essentially what we do is we take a small portion of a sample, we introduce, depending on the drug we're looking for, we introduce different antibodies and proteins. And those antibodies and proteins have an interaction where they want to connect with one another. But what ends up happening is a drug particle gets in the way. And when it gets in the way, it creates this displacement, which we're able to measure on our equipment. And that's what gives us a positive test result. So here's the non-scientific version of that previous slide. So we can kind of look at screening testing as a lock and key system. So the screening works off of structural similarities. So if we're looking for a key to unlock a specific lock, the key representing a drug, this drug has just the right amounts of peaks and valleys, represented by a key again here, that will fit in and unlock this lock. But what happens in cross-reactivity, or the false positives, there is a other drug or maybe even an unknown non-drug particulate that's in the sample that has a structural similarity, enough of these peaks and valleys of the key we're looking for to also unlock that lock. Here's a nice visual of cross-reactivity. So in this case, our intended analytes are amphetamine and methamphetamine. And you can not only see that they have a similar structure to one another, but also a handful of other drugs here below. We spoke about pseudoephedrine as an example. You can kind of see here how closely similar structure-wise it is to methamphetamine and amphetamine. Now here's a list of some well-known cross-reacting sources. This is by no means a comprehensive list, but I always like to point out dextromethorphan on this list. It has the potential to cross-react for PCP. Dextromethorphan is a drug found very commonly in a lot of over-the-counter medications such as NyQuil and Dayquil. So a lot of over-the-counter cold and flu medications contain dextromethorphan. And if found in high enough quantity, it has the potential to give us a positive for PCP in the screening test. Now, if we look at that previous slide, but through the lens of conformations, here we're not looking for structural similarities, but differences. So now, which of the below or the previous examples would cross-react for methamphetamine or amphetamine in a conformation result? None of them. Again, we're looking for the exact chemical structure in a conformation, so there's not going to be any false positives on a conformation test. Now let's take a look at the different testing matrices that we look at here. Now, the majority of drug testing, the test is typically urine. It has a long history of use, and many of our clients are comfortable with its interpretation. However, there are alternatives, such as oral fluid, blood, and hair, that can be very valuable and provide additional information. We get this question a lot: what is the best drug testing matrix? There's really no best. It all depends on what information you're looking for. Are you looking for past exposure, recent impairment, recent drug use, or maybe a longer window or history, such as 90-day in hair? So before we dive into each of these ones in detail, we're going to take a look at the general drug detection windows. If we look at oral fluid being represented by this blue line here, we can see that drugs and oral fluids start showing up very soon after consumption, within the hour or so. But the maximum detection window is about 36 hours. So the window typically for most drugs and oral fluid is 1 hour to 36 hours. If we look at urine, represented by this green line here, we can see drugs also start showing up in urine very soon after consumption, again, within an hour or so. And we have a bit of a longer detection window. It's typically 2 to 5, 3 to 5 days for most drugs. And there's some exceptions that we'll get into, but again, general drug detection windows we're looking at. Now, if we take a look at hair, being represented by this orange line, we can see it takes quite a few days to start showing up for drug usage to start showing up in hair. It's about 7 days Drugs are actually deposited at the root of the hair follicle, and it takes about 7 days for that portion of the hair to grow above the scalp to be included in any collection. The maximum detection window for hair is about 90 days or 3 months, which is quite a long time, but there's some special caveats to that, which we'll get into here in a moment. Now, before we get too far, I do want to say, regardless of what we're talking about, whether it's urine, oral fluid, or hair, our drug testing does not, it only tells you if a drug is present. It does not tell you how much of a drug was consumed, when the last time the drug was consumed, the impairment of the donor, or in the case of treatment, the advancement or state of disease. So taking a closer look at urine, again, urine is the most commonly utilized matrix in toxicology. We have a long history of use, and it provides us a good detection window for most drugs, again, 2 to 5 days. Some benefits to take into consideration is that typically we have a large volume that's been collected, so you don't have to worry about running out of specimen too much if there's a lot of confirmations or additional testing that needs to be done. It does a good job of looking at and picking up levels of both parent and drug metabolites. It's typically the most cost-effective of the three drug testing matrices. We have a good detection window, and we have a very large drug testing menu for urine. Some special considerations is, number one, if you're doing a properly observed collection, that would mean seeing urine directly leave the donor's body. So that can be very invasive, and it requires the same-sex collector. So that's a special consideration that needs to be looked at. Also, urine can be subject to adulteration or dilution both before the specimen is collected and after. We'll take a little bit closer look at how that's done in the next few slides here. Taking a closer look at oral fluid. Now, for some reason, there's a common misconception that oral fluid is inferior to urine. I can tell you that it's as sensitive and as accurate as urine testing. I think most people are confused about what the use of oral fluid is. It does have a much shorter detection window, again, about 1 to 36 hours, compared to urine's 3 to 5 day there. Now, oral fluid is a popular alternative to urine, and it does have some advantages. It's a direct filter of the blood. We'll take a look at what that means in the next slide here. Now, some special benefits to consider is that oral fluid's non-invasive and it's gender-neutral collection. So unlike urine, it's less invasive, and you can have a male collector collect for a female donor and vice versa. Just by the very nature of the collection process, there's very little opportunity for adulteration or substitution. And it's a good testing protocol randomizer. Now, what does that mean? If you have a donor that's standing in front of you right then and there, and they're acting a little bit off or funny, or maybe they recently admitted something to you, it's really easy to pull out an oral fluid collection and do it right then and there. It's also a good way to mix things up a little bit if you have a donor on a testing frequency and for some reason you just feel all the urine tests they're somehow getting away with something. It's real easy to throw in an oral fluid test to kind of mix it up. That way the donor would be quote unquote unprepared to subvert or adulterate another urine test because it'll be oral fluid. Now, some special considerations is that it primarily detects parent drugs, not so much metabolites. We'll take a look at why that is in the next slide. It's typically more expensive than urine testing, and we are working with a smaller volume of specimens. So there can be a concern of running out if there's a lot of additional testing or confirmations that need to be done. Now, as I mentioned earlier, oral fluid is a direct filter of the blood. It's not a reservoir matrix like urine. So this means it provides us a snapshot of drug actively circulating in the bloodstream. Now, in the body, drug metabolites are rapidly cleared from the blood through the liver and kidneys. Thus, circulating metabolite levels are very low. So oral fluid is primarily going to detect parent compounds and not so much the metabolites because of that reason. You will expect to see mostly parent drug and not the metabolites. You'll see some metabolites, but don't be surprised if you don't. Oral fluid will have much lower cutoffs than in urine and will give you a direct window of very recent use versus that historical look back like urine does. Okay, finally taking a look at hair. As I mentioned, we have a very long detection window, about 3 months or 90 days. Now, there is a caveat to that. It takes multiple moderate uses to show up in hair. So this is more to establish a lifestyle choice rather than in urine a one-off drug detection. So it's a good way to establish a baseline on a donor. Now, if I took, let's say, as an example, a little bit of cocaine 3 weeks ago, hair testing is not going to necessarily pick that up. Again, it takes multiple moderate uses or heavy use to be picked up. Some benefits of hair is, again, much like oral fluid, it's gender neutral. We typically have a large volume that's been collected. And much like oral fluid, just by the very nature of the collection process, it's difficult to adulterate or substitute. Now, some special considerations is that some drugs do not go into hair well, such as THC. It's typically the most expensive out of the three tests, and it's not going to pick up recent drug use. Again, it takes about 7 days for that portion of the hair to grow above the scalp to be included in any collections. And the laboratory that we use for hair testing does wash the hair to ensure any external contamination is not present during the testing process. All right, let's take a look at creatinine here. Now, creatinine is something we test for in every single urine specimen that comes through the lab. And creatinine is very important in determining if a specimen is valid to test, essentially. So let's start with what is creatinine? Well, creatinine is a chemical waste molecule generated from your muscles, and it's metabolized through the kidneys. So someone being awake right now, just moving around, their muscles are, as a byproduct, producing creatinine, and that creatinine comes out in your urine. Now, that creatinine level that we're looking for is not affected by diet or normal physical activity, and it's produced at a constant rate for every individual. So what really determines that creatinine level is the hydration status of the donor. A well-hydrated individual is going to have lower creatinine levels, and a dehydrated individual will have higher creatinine levels. Now, creatinine levels are going to vary tremendously from not only one donor's specimen to specimen, but also from donor to donor, of course. Now, what is a normal creatinine value or level? Really, anything above 20 milligrams per deciliter would be considered concentrated enough to be confident that if there is drug present, that it would be picked up in that specimen. Now, how easy would it be to get a creatinine level under 20 milligrams per deciliter? Well, if we took a population, a random population sample size from everyday folks walking on the street, we'd expect less than 2% of them to have a creatinine level under 20 milligrams per deciliter. So it can actually be quite difficult to dilute your sample. Now, if you have a donor who's an athlete or maybe taking medication that requires them to drink lots of water, or maybe they are in a profession that requires physical manual labor and they're outside in the heat all day and they need to push water, it might not be unusual if they're flirting with that line, if they're getting 20, 19, maybe even 18 or 17. When they start getting much lower than that, then it becomes a little suspicious whether or not it's intentional. Now, if you have a donor who you feel is not doing this intentionally, but they are flirting with that line, you can advise them on a few things that they could try and implement to get a better chance of a more concentrated specimen. The first would be to make sure that the donor is not drinking more than 8 ounces of any type of fluid an hour prior to their test. You could even push that out to 2 hours. You could also try to have them go first thing in the morning. Typically, the first void of the day is going to be the most concentrated. The idea being that the donor is going to be asleep for the night and they wouldn't have time to push a lot of fluids before their test. The last thing you could try and implement is work with the collector or a collection site to do a midstream collection. Typically, the first portion of any void is going to be the most dilute. Now, dilution is the most common method used by donors to try and subvert their drug test. This can be done in two different ways. The first way, and by far the most common way, is the donor would consume large amounts of liquids prior to their test, and that includes any type of liquid, water, soda, coffee, tea, any type of liquid would contribute to a dilute sample. The second method, which if good standard collection processes are being implemented, should be less of a concern because the donor wouldn't have this opportunity. But the second method would be adding liquids to the sample after the collection. So if the donor's left alone in a room with their sample, they might be able to substitute their sample with something that they've brought in with them, artificial urine or juice or something like that. Or maybe they take water out of the toilet, or maybe a tap wasn't shut off, and again, they're being left alone in a bathroom and they're able to dump out their specimen and fill the cup up with water. Um, now, again, creatinine is very important because it is directly correlated with the amount of drug we would expect in a sample. So, in this example, a donor drank so much water an hour prior to their test that the resulting creatinine level was 10 times more dilute than normal. This means any drug that are also in that sample would also be 10 times more dilute, and therefore all levels of a drug we're looking for, say methamphetamine, would be dilute below the cutoff, resulting in a negative test result. Now, if you get a positive, but the sample is dilute, that positive is still good. That positive is still worth getting a confirmation on. That only tells you that not only did a donor come up positive, but they also tried to subvert their drug test. Now, we do get a question quite often of I have a donor taking a diuretic, and they're saying that's why they're coming up dilute. A diuretic might help potentially push a donor off the edge if they're already flirting with that line, but a diuretic is not going to take a good concentrated sample and pushing it so low that it becomes dilute. So they'd already have to be flirting with that line or dilute for that diuretic to really impact the specimen or the outcome of the results there. Now, another question we get is, I have a donor that is taking creatine. And I'm worried that they're artificially concentrating their sample, or maybe that's contributing to a dilute sample, et cetera, et cetera. Creatine is a dietary supplement that a donor can take. It's usually consumed for muscle growth and muscle development. Just because they sound similar doesn't mean they are similar. Creatine really has nothing to do with creatinine, and it's not going to impact that level in any significant way. Okay, segueing into THC. This is a good segue because THC does rely quite a bit on the concentration of the specimen and the creatinine level. Now, THC is a little bit unique in that, unlike other drugs, it can stay in a donor's system for quite a long time. So marijuana can persist in urine long after use. If you have someone who's a light or an occasional user, it's going to look a lot like that standard detection window of most drugs of 2 to 5 days. But if you have someone who is a heavy and frequent user, it can stay in their system for upwards of 6 weeks. So What we're able to do is do a little bit of math for you, and because it stays in a donor system for so long, we have to have a way to know if when we're testing a donor 4 weeks after their first positive and they come up positive again, is that residual from the first test that we're picking up, or is this new use? So what we do is we do a little bit of math for you, and we come up with the THC creatinine ratio. Now, when we're doing this comparison, we want to make sure that we're looking at confirmed test results. So again, that LCM SMS and comparing those together. We want to try and compare at least 3 test results that are 3 to 5 days apart. Now, there's some general rules of thumbs you can do to try and do this interpretation, but if you're a client of ours, I would encourage you to reach out to our client service team and they can help you make this determination. If they're unable to, they can get our lab director involved and help. But some general rules of thumb is that THC creatinine ratio should decrease by half or more every 2 to 10 days. Just know it'll decrease much faster for an occasional or light user. And if that THC creatinine ratio doubles or greater between 2 samples, that's typically consistent with new use. Now, these are general rules of thumb. When you start dealing with really low ratios, that's when you have to take some caution. And that's when I encourage everyone to reach out to our client service team. Low THC creatinine ratios and low THC levels can be tricky and may not indicate new use. These levels could be consistent with the end stage or trickling out of THC metabolism from the fat cells. So that's why it tends to kind of stick around a little bit longer than expected when you're dealing with those lower ratios. Now we have an example here. How's my client relapse? We have a handful of results. If we take the THC level and plot them on a graph here, we can see that the graph goes down, and then it pops back up. So would this be new use or not? Well, we're missing a huge key factor, which is the creatinine level or the THC or the specimen concentration. So now when we take that same example, but we take into consideration the concentration of the specimen, we see here that it goes down and it goes down, and then it continues to go down, indicating no new use in this example. All right. So with the legality of THC and CBD across different states, this question has come up quite a bit. Can CBD cause a positive for our THC test result? Now, our standard THC test is looking for the particular structure of delta 9. Now, CBD alone will not cause a positive for delta 9 THC. However, CBD products in their production are unregulated and can contain levels of delta 9 THC. So this may produce a positive result in urine. Some states have a lot of legislation around CBD products and how much delta 9 or THC a product can have. Usually I know in some states it's below that 0.3%. Even that low level, if taken enough in high enough dosage, can cause a positive test result. So can CBD cause a positive for delta 9? Yes and no. Now that brings us to delta 8 THC. So delta 8 is new. It's a way manufacturers are trying to get around delta 9 THC when either maybe it's not legal in your state or you need a green card, or maybe you're on probation and you shouldn't be taking this. Delta 8 is largely unregulated and it's often found in gas stations, head shops, and online. Now, Delta 8 is found in the marijuana plant, but it's found in a much smaller quantity, a lot lower level. So what manufacturers of this are doing is they're concentrating the levels and marketing it as essentially a way to continue to use THC, but not get around any testing or blocks that donors have. Now, can delta 8 cause a positive for our THC test? Again, that's a yes and no. So what we're seeing in our testing when a donor is consuming delta 8 is usually the screening test is coming up positive. And when our clients are asking for a confirmation, what they're getting is a result that says could not run or did not result, something to that effect. What's going on there is that our lab techs are seeing that there is something there, so we can't call it negative, but it's not lining up with delta 9. So it's not lining up exactly with delta 9, so we can't call it positive. We have a test called a cannabinoid test now that tests for delta 8, delta 9, and CBD. So if you're getting that test result, I would encourage people to order that cannabinoid panel. Alrighty. A few quick commonly asked test interpretation questions here. We get this quite often. I have a donor coming up positive for morphine. They're saying they ate a poppy seed bagel 2 days ago, and that's why they came up positive. Is this true or false? Well, when we're looking for things like morphine or heroin, we're looking specifically at morphine and codeine. But morphine levels can be picked up when someone is eating poppy seeds. So now the detection window of morphine is just like the standard detection window, 2 to 5 days. And what we're looking for here is whether or not the level of morphine is above or below 2,000 nanograms per milliliter. And you'll see in our test results in the notes section, if you have a morphine level that's under 2,000 nanograms per milliliter, you'll see the results say that this result could be due to morphine, codeine, heroin, or poppy seed consumption. So in this case, poppy seeds are technically possible in this situation. Now, if the level is above 2,000 nanograms per milliliter, that's no longer plausibly from poppy seeds. And you'll see our notes on our test results reflect that. You'll see morphine. This result could be due to morphine, codeine, or heroin. Now, 2,000 nanograms per milliliter is quite a large level. What's the likelihood that we're getting higher levels from poppy seeds? Well, there was a study done quite some time ago, but it still holds up, where a handful of participants were given poppy seeds to ingest either in a roll or raw. And over a period of time, the study runners collected specimens on these donors, both urine and oral fluid. And here's what they found. So the highest level of morphine they got in urine was 4 hours after consumption, and the highest level it got was 697. That's even more exaggerated in oral fluid, where 2 hours after consumption in oral fluid, morphine levels stopped showing up. So is it possible? Yes. Is it probable? I would say keep an eye on those morphine levels and monitor those and see what's going on with that. Here's where a zero tolerance program really comes into play here, where you can just say, guess what? You're not eating poppy seed or anything with poppy seed. It's up to you to make sure you know what's going into your body here. Alrighty, let's talk about ethyl glucuronide and ethyl sulfite, or ETG and ETS. These are alcohol metabolites. Ethyl alcohol, we can test for, but the detection window in urine is about 24 hours, so quite a short period of time there. But with the metabolites, our detection window gets bumped up to about 80 hours in urine, which is fantastic. However, there's some special circumstances that everyone should be aware of. Now, these circumstances take very specific environmental factors to be introduced, and is very specific. So this is going to be a rare situation, but there can be what's called post-collection synthesis of ETG and ethanol. So if you have a donor with uncontrolled diabetes, or maybe undiagnosed diabetes, there can be excess glucose or sugar in their urine. The sugar can ferment into alcohol if the right environmental factors are introduced. And if you combine that with poor hygiene, or maybe a donor has a UTI at the time, a urinary tract infection, there can be E. coli in the sample. Now, E. coli with alcohol can metabolize ETG. So there can be ETG in a sample from this situation without a donor consuming alcohol. Now, that's all said and good, but what is unaffected by all of this is ETS, or the ethyl sulfite. It does not have the same phenomena. It is very stable in urine. So when we're doing these interpretations, we kind of want to focus in on the ETS there. So here's the 3 different possible outcomes that can happen with test results. So the first one would be a high level of ETG, 0 level of ETS. Is this connected with alcohol consumption? Well, further evaluation would need to be done before taking action, right? You chat with the donor. Are you diabetic? Have you been diagnosed with diabetes? Did you have a UTI at the time of this test? Things like that. The next example would be, we have a high level of ETG and we have a good level of ETS. Because of that level of ETS, we can say that this is consistent with alcohol consumption. And then finally, we have no ETG, but we have a level of ETS. Because of that level of ETS above the cutoff, this would be also consistent with alcohol consumption. Now, our test for ETG and ETS at Cordant is very, very sensitive. There are a lot of products out there that have alcohol in them that if donors are ingesting, they can come up positive for ETG and ETS. I would say if there's any hesitation or any question, give our client service team a call. Now, current studies suggest that a ETG level greater than 500 nanograms per milliliter would indicate consumption. Again, if it's really high, you may want to, and there's no levels of ETS, you may want to ask a few questions of the donor. Are you diabetic? Did you have a UTI? Things like that. So these tests can pick up incidental contact. So just be aware of that. All right, moving on to myths and facts here. So we get this question quite often. I have a donor that insists that they didn't take fentanyl. It's not really their drug of choice. Why is it there? Clients may indeed, they may or may not know they've ingested fentanyl or other fentanyl analogs. This is because we're seeing an expanded number of what we call polydrug combinations on the market. So that this means that illicit manufactured fentanyl is being used to replace or adulterate other drugs of abuse. So it's often mixed with cocaine, heroin, and methamphetamine, as well as manufacturers are making counterfeit pain pills such as oxycodone and passing them off as just safe oxycodone. So because it's very commonly mixed with other drugs to increase potency, reduce cost, and increase addictive nature, donors may be coming up positive for fentanyl when they're unaware and it's not their drug of choice there. Now, this is relatively new and we're still gathering information on this, but there is a certain situation where we're finding norfentanyl, which is the main metabolite we're testing for when we confirm for fentanyl. We also look for norfentanyl, which again is that main metabolite. We're seeing that norfentanyl is tending to stick around a little bit longer than that standard drug detection window, that 2 to 5 days. It's acting a little bit like THC in that it's staying in the donor system for a bit longer. So unfortunately, there's no guidance we can provide of what level of norfentanyl and fentanyl would indicate new use or residual use. There's no perfect way of knowing. What we can say is that fentanyl seems to be maintaining, the parent drug maintains that detection window of 2 to 5 or 3 to 5 days, right about there. And much like marijuana, norfentanyl sticking around takes multiple and frequent and heavy use of fentanyl to start acting like marijuana. And unfortunately, the potency of fentanyl is that a donor that is taking multiple heavy uses of fentanyl is they don't have a very long life expectancy, so that we expect this situation to be rare. And finally, this one's always exciting. We always get this one. I have a donor that's saying that they're at a house party and someone was smoking marijuana around them, and that's why they came up positive because of secondhand smoke. What is the validity of this? Um, well, it's possible, but it's usually false because certain criteria must be met for this secondhand exposure to come up positive. First of all, there has to be very poor ventilation or no ventilation at all in a very small environment. They have to be in this environment for an extended period of time. And usually the person's going to feel the effects of the drug. So at one point, you might have to ask whether or not this exposure was intentional or not. And you can often ask donors, do you need to be in that environment? Should you be hanging out with that element when you're on probation, if it's a probation setting? So a lot of conversations can be had. And this goes for all drugs that are smoked, whether it's THC, methamphetamine, or crack cocaine. Alrighty. The last thing I want to touch on is if you go to our website, if you give us a Google, Cordant Health Solutions, or it's cordantsolutions.com online, we have a lot of fantastic resources. Here's an example of a benzodiazepine drug metabolism chart. So if you have a donor taking a specific drug, we can often look at what metabolites are coming up positive and make a determination whether or not what they have been prescribed is consistent with what we're seeing on the results. But again, I encourage everyone to go to our website, take a look at our resources. We have a lot of fantastic webinars, and we have a lot of fantastic documents there that dive deeper into some of these drugs. So I appreciate everyone's attention and your time, and I hope you all have a good rest of your day. Thanks.